Hi everybody, welcome to our board meeting in January. Good to have you all with us. We've got a really great agenda today, so let's get cracking. Apologies for absence from Dean Royals and Priyanka Pereira as well. Are there any other apologies? No? Okay, thank you very much. Declarations of interest. If there's any changes, please let Laura Roberts know. Are there any matters on the agenda that present a conflict for any board members today? No, thank you very much indeed. We'll move on then to the minutes of the meeting held on the 27th of November 2024. Are there any corrections from those minutes, for those minutes? No. Are we happy to approve the minutes? Yes, okay. We'll move on to item number 4 then. Any matters arising from obviously the minutes and the action log or the work plan, please? Put your hand up to let me see. No, I can't see any hands up. I'll wait a little bit. No, that's okay. Thank you very much indeed. And I'm really delighted that we can now move on to our patient story item and staff story. And we've got some great colleagues with us today, and I really appreciate both our staff members, but also our colleague Charlotte, who is a service user as well, who's also moved into some work in this area as well. So that's a brilliant journey in of itself. Really glad to have you with us and hear more about yourselves and your work and what's happening. So I don't know if one of the executive members wants to say anything who leads in this area before they start. Kwame?
Yeah, no, I'll ask Rebecca to start and then introduce the colleagues and then pick up. Thank you very much for coming to share the story and to talk to us today.
So over to you.
Thank you for inviting us to come and share our story today. So as you all heard earlier, I'm Rebecca Wilkinson. I'm the service manager for Op Courage in Humber in North Yorkshire, and Charlotte, who is in the room at HQ with Fernanda from the PACE team, are here to talk about their experience of the service. For those of you that don't already know, the Op Courage Veterans Mental Health and Wellbeing Service operates across the whole of England. In Yorkshire and Humber, we're part of a provider collaborative led by CNTW for the north of England, which is made up of both NHS trusts, Walking with the Wounded, which is a service charity which offers welfare support for the veterans that we see, and also employment-based support. We also work alongside Combat Stress, which adds the substance misuse element of our pathway, and peer support for the veterans that we're working with. The need for specific veterans mental health services first arose with 6 MOD pilot sites for PTSD, of which the Humber Traumatic Stress Service was one. It was then identified that a cohort of veterans were being missed, those that might not attend their GP surgeries for referral, that didn't want to identify or maybe didn't have a PTSD diagnosis. Fighting Fit, a report by Andrew Morrison in 2010, identified these groups as being at risk for not accessing services, and across England, specific services aimed at this group of veterans were commissioned. And within this locality, you may have heard of it as the Veterans Outreach Service. These services have now evolved, going from the TILS Complex Treatment Service and Enhanced Veterans Mental Health Services, and are now all under one umbrella, which is the Op Courage service that now exists. The service acts as a one-stop shop for veterans and the armed forces community, offering specialist triage, assessment where appropriate, and then either referral to an appropriate service that would be supported by us to ensure engagement, or an intervention and therapy offered within our service. Op Courage is for those veterans that wouldn't otherwise access services. We're not for every single veteran. We are for those that are struggling to engage locally. We would seek to support them to engage to do that. We aren't here to replicate or replace existing services, so we offer support to local mainstream services to help the veterans they're working with remain engaged, and to help the armed forces community to access the right service for them at the time they're seeking support. We work flexibly to meet the need of the veteran and their family, and as a team we're made up of veterans, Ministry of Defence staff, veterans' families and serving families. but also we have civilian staff with a good understanding of military culture, because not every veteran wants to speak to somebody that has served. We utilise assertive outreach techniques to engage with the veterans and help them to get ready for referral to mainstream services or therapy within Up Courage. We use venues for appointments that work with the patient group we're seeing and help them then to transition to more traditional venues. Talking about how you feel is really hard, but even harder for some to sit still and do this in a room. So walk and talks are a really useful tool that we use to build rapport. Transitions are important, and we see those people that aren't quite veterans yet. Within 6 months of discharge, we see serving soldiers to help them to navigate the outside world, to ensure their families can access the support they need to and are linked with the services that they need. Most importantly, we're a self-referral service with no wrong front door. So we're operating across the north. Wherever a veteran accesses Up Courage, we will ensure that they access the most appropriate service for them. The majority of referrals do come locally from individuals themselves, and we triage that referral within a day of receiving it. They're offered an appointment within 10 days, although this is often much sooner than that, and treatment within 4 weeks of this, but again, often much sooner. We are very flexible. We offer them virtual or face-to-face appointments, but a lot of the veterans find virtual appointments work well for them. If they're in employment, it fits in their lives and allows them to seek the care they need. It also reduces some of the stigma that they feel themselves and that's felt within military culture, because they can access services without having to advertise that they're coming into mental health care. I would now like to introduce Charlotte. She'll tell you her story of accessing the service, the barriers she's encountered prior to this and overcame. I'm very grateful for her to being willing to speak about her journey, and I hope that this story is shared much further for those veterans struggling to access services. Hearing that it actually works is often the push that makes them seek help or keep going for the same result as their peer.
I was first diagnosed with PTSD in 2006 after my first operational tour as a combat medical technician. Subsequently, I underwent various treatment methods under DCMH and deployed on a further 4 operational tours of Iraq and Afghanistan. During this time, I battled with my personal demons and found it very difficult to discuss my feelings with anyone connected to the military because of the stigma attached to mental health and the supposed weakness that was connected with mental health conditions. In 2013, whilst working in a recruitment role, I sought further help from DCMH and was placed on sick leave. In 2014, I got married to my husband, who was still serving. Due to the medication that I was taking, my wedding day wasn't the fairy tale that I imagined.
Don't worry, take your time. It's fine. Stop if you need to.
It's all right. And it was devoid of emotion and feeling. A few months later, the medical board deemed me unfit for any further service and recommended that I was medically discharged from the army, which happened in mid-2015. No, it's okay. Yeah. In the run-up to my discharge, I was offered one last round of EMDR. I was also pregnant with my first child. Throughout the first 6 months of the pregnancy, I was on medication for PTSD. I was assured by a military doctor that the medication was safe during pregnancy. Whilst pregnant, I had become quite unwell mentally and was having thoughts of harming myself. My husband was away multiple times during this time, causing me to spiral further into my depression. I eventually found myself as an inpatient at mental health hospital, where I was removed from my medication called Turkey. In 2016, my husband was posted to Cornwall, where I couldn't have been any further away from my support network. When we first arrived, my son was 6 months old, and we were housed in the middle of nowhere. This didn't help my postnatal depression, which was later diagnosed, or my PTSD. As soon as we arrived and unpacked, my husband was sent away for 6 weeks, leaving me alone in a new place with our young son with no support or help from the military. Whilst in Cornwall, I had approached the GP for help with my mental health. I was told to take these pills and you will be okay. I walked out of the GP a little bit confused. I knew the services were out there, but was being given meds and sent on my way. I spoke to the welfare team at the unit, voicing my concerns about my mental health. I was told to leave my husband and go live up north. He can come home once a month. I approached the GP again because I didn't want to leave my husband or take medication. And the doctor told me if I didn't take them, he couldn't refer me to the specialist that I needed help from. In 2018, the thoughts of suicide started to creep back in. I was functioning well outside the home, at work and holding it together for outside world, but the minute I walked back through the doors at home, I fell apart completely, trying desperately hard to stay alive for my son. I didn't want to die. I wanted the darkness to end and the nightmares and the guilt to stop. My husband told me to speak to the welfare officer. I messaged her on social media whilst watching my son play at a soft play centre. We were moved 8 weeks later, but in the process, they had responded asking if I wanted help and if she could refer me to a veterans mental health service. I was very grateful for any help I could get. I'm still in touch with them to this day. We moved to Catterick, and this is where I met Rebecca from Humber Teaching NHS Foundation Trust. She became a solid part of our lives for 3 years. Together we worked closely on my goals and what I wanted to achieve. I just wanted to be better and happy without meds. We met monthly to begin with. Each time Rebecca gave me homework to do. I was evaluated for EMDR treatment again in mid-2019. This was until I found out I was pregnant again with my daughter. Rebecca helped me access help and support for the pregnancy-related mental health, which I was very anxious about due to the issues I had experienced with my son. We began to meet more regularly, building up my coping mechanisms for upcoming anniversaries and challenging dates such as Bonfire Night and Remembrance. Rebecca instructed me not to hide away from fireworks, but to embrace them. So we all went out, went to an organised display. I personally thought she was crazy for suggesting this, as did my husband. It worked though. There was no flashbacks. I cried silent tears watching the fireworks. It caused me to remember my fallen friends rather than fall to the ground in fear or cause weeks of nightmares and flashbacks. Watching my son enjoy them and me being able to enjoy the fireworks with my son and my husband, it seemed like an unlikely event. Yet there was a field of hundreds of people giving it ooh, ah, at all the colours. Rebecca told me that I didn't need to attend any remembrance parades and I should remember my colleagues how I wanted to, rather than how society and the forces and ex-forces community expected me to remember them. This relieved some pressure that November usually brought with it. Soon there were details of my daughter's birth to deal with. Rebecca helped with the smoothing out of the wrinkles in my very strict birth plan. Helped me put rules in place to allow me to feel in control. She helped me learn to advocate for myself. She attended perinatal meetings in regards to my mental health during my pregnancy and birth. Just before I was due to give birth to my daughter, the country closed. We were locked in our houses, only allowed out for essentials. My daughter was born 5 days into a global pandemic and a national lockdown. I was homeschooling my son with a newborn. I received continued support from Rebecca through weekly phone calls for the first couple of months. She'd become able to read the tone of my voice and was able to tell when I was doing well and when I wasn't. When the world started to open again, I received at-home social distance visits fortnightly and phone calls on the weeks I didn't have a visit. It had been arranged that I would start EMDR treatment with the perinatal team in September 2020. This was done online. This was done at a time my husband had been sent away somewhere for weeks. I was left at home with 2 children, trying to sort my mental health out without my biggest supporter. I didn't have my children. I didn't have any childcare for my daughter due to me not being a key worker or being able to afford childcare or maternity pay. To enable the treatment to take place while my husband was away, a friend had to come and stay in the garden with my daughter. This continued until December, when my husband wasn't away. He was unable to get home to look after our daughter whilst I went through EMDR because of his work commitments. On the rare occasion he was able to get home, he was usually late, by which time I'd called my friend to look after my daughter. My EMDR treatment finished at the start of December, and we were moving again in January 2021 for another posting. Rebecca had always been at the end of the phone throughout my treatment. She visited us in our new home, much closer to where she's based, right up until September 2021. Being a constant in our lives and helping me overcome little hurdles I would encounter. They would seem small and minimal to regular people. However, there was a part of my brain that would blow them up bigger than they were. Rebecca had always encouraged me to follow my hopes and dreams, and nothing was impossible. I had come too far to give up. I applied to university not long after moving and was offered a place on the degree which would lead me to the job I dreamed of for 10 years. It says here that I'm going to be an operating department practitioner, but I qualified in September. I wouldn't be if it was. Sorry, I wouldn't be here if I hadn't been referred to Humber Tills. I'm forever grateful that Tills and Rebecca came into our lives when they did. I am proof that PTSD doesn't define who you are or a label that needs to be worn. Scars show where you've been. They do not dictate your future. Do we need to read that? Yeah, if we've got time. Whilst on my first operational tour of Iraq, I was written up to receive a Queen's Commendation for valuable service. I was presented a huge picture frame with my citation, the commendation, a copy of the London Gazette I was named in, and a small ribbon with the oak leaf on. This used to hang in my mum's hallway. She was immensely proud of it. I wasn't. It was just reminded me of my failings as a medic. I had failed to bring 3 guys home. They were returned to the UK in boxes. When I got married, my mum thought we should have it. For years, it moved with us being every quarter. I didn't want it to be hung. My husband insisted he would hang it and I would take it down. After treatment with Rebecca, the picture frame and its contents hang proudly by our front door. It's the last thing I see before I head upstairs in an evening, reminding me of what I've been through and what I have overcome to get to the point I am now.
Thank you so much. Thank you so much, Charlotte. And can I thank you for your service and your husband as well to our country. The armed forces and our health services sometimes don't work and they fail. And your story, both as a serving a soldier, but also a medic, but also as a family member, just reminds me how, actually it is for our serving personnel, but families, how they're affected when someone they're, married to or with is away overseas, or you're moving around the country constantly and hard to get the sort of consistency of services that you need. So you really appreciate you sharing that. And to be honest as well, if I may say, it's good to have you here as a woman who's a veteran as well, because so often we hear from men and that's fine, but this is for women as well, isn't it, in terms of how PTSD affects us as women too. So really thank you for that, and I appreciate. And to Rebecca, thank you too for your service. Thank you for what you're doing as well. You've done a terrific job working with Charlotte, and I'm sure many others, and just hearing about the perinatal service, that's something, again, we're very proud of, and we're pleased to see that that's expanding too. So I'll move to my colleagues now, who I'm sure would want to ask some questions as well. Can I see some hands, please? Phil.
Charlotte, thanks so much for sharing that. It's very insightful. I'm an ex-GP, and I'm always embarrassed when I hear that the doctors go to the prescription pad up front, and it's really, important that we hear stories like this so that we understand that expert advice and support is available, and that we think about that before we think about the prescription pad. But I really appreciate it, because obviously it's cost you to bring that to us this morning, and I really appreciate that you had the courage to do it, and it's very helpful. Thank you.
Thanks, Phil. Lynn?
Yes, thank you, Charlotte. I think I agree with absolutely everything Caroline has said. So just a real big thank you. And thank you so much. There's so much in your story I could actually pick up and ask you some questions about. But you did start your story by telling us how difficult it still can be in the military or not, I suspect, to raise issues that you have around mental health issues. But given we do have this TIL service that you've been really positive about, Charlotte, so thank you. Is there more that we could be doing sort of through that service and wider, do you think, around that stigma that you raised?
I mean, I've been out the military now, well, it'll be 10 years this year, so I can't comment on recent stigma. But from what I've seen through my husband, I mean, his service finished in August. It's better than it was, but that's because the old and bold, as we should say, have retired and come to the end of their service. And you're now getting a new generation of leaders coming in who have experienced the traumas, shall we say, of Iraq and Afghanistan, and the recent conflicts, and they know it's okay to not be okay. So as a NHS service, I don't think there's anything that you guys can change within the military, other than promoting outside what the service is and has to offer.
Maybe it's something for colleagues around the table as well, Rebecca, and how we can take that forward as well. Maybe that's a conversation I can pick up. I don't think there's we can do more. We just need to keep on thinking about it, because people accessing our services is absolutely key, and you've demonstrated that, Charlotte, haven't you, that when you did, bumpy road though it was, the service has been helpful to you. But thank you again. It's just amazing and really well done on your career as well.
Thank you.
Stuart.
Hi Charlotte, I'm Stuart. Just want to echo what my colleagues said about your performance there, just so moving. I have a nephew who is a combat medic, so I've got a sense of what you have to do. He doesn't share much about what he saw, but I can't imagine what it's like to go through what you've been through, but I want to say how much I admire what you've just done for us. A lot of what you talked about was about the past. Thinking about the future, you've just done a degree. What do you hope for your life and your children the next 5 years, say?
Oh, I'm just thinking about tomorrow, if I'm honest.
Yeah.
But it's I want to continue being PTSD free. My hopes and dreams, I mean, I'm happy as a little band 5, just pootling along. There's no stress, no worries. Well, there's stress and worries, but I am working with Rebecca and Greg to try and get more female veterans to access the service. I was part of a focus group before Christmas, I think, and I've got a roundtable with NHS England next month. Unfortunately, I have to attend it remotely because I've got nights.
Yeah.
So I'm just trying to advocate for the service and to prove that you can beat PTSD, and I am living proof that you can beat PTSD. You don't have to make it your entire personality.
Yeah. And you are a brilliant advocate.
Thank
Thank
you.
you.
Michelle.
Yes, thank you. I'm Michelle, Chief Exec, and thank you. What a courage it took, and what a great congratulations, and what a great progress that you've made. And a lot of my questions have been asked, and I was really quite interested about your future and how we can help support you going forward, but also to develop and to bring more veterans into the service, because I think what you've said then is really important. It is okay to not be okay. And how do we get that message out to people and to support people? And we have to keep doing and supporting you and hearing your story. And it was a great moving story. Emotional about it, as you can probably tell. I was going to ask about if there's anything else that we could do, picking up a bit about Lynn's point, not just about the stigma, but about the service, about the access. Is it reactive enough? Do we help you reach out to people? You mentioned the round table. So it's a bit about how we can support you in that, but from a service point of view, is there any gaps that we need to maybe look at? And just to thank the team, but certainly thank you as well, and thank you for your service, but also for the courage that you've had to come today to meet a load of people around a table on a screen that you don't know and share that story. So it was fabulous. But thank you so much for that. But anything else that we can do? Do you think that we can take away today?
I mean, I did speak to Greg the other week about using, because the generational gap are more in their socials and in their social media and their Instagram and their YouTube. So I don't know, maybe some YouTube shorts about the service, just sort of branching out into more, not technology, what's the word? I don't know.
Yeah, it's more accessible to people.
Yeah, being
Social
more,
media.
yes, using socials more. Because I know some people, there's a Facebook page called Fill Your Boots, and he completely and utterly annihilates the military through humour, but he will also help people that are struggling with their mental health. And I will always comment on those posts saying, get yourself to Up Courage, do this, do that. You don't have to you can survive this. And then there are people going, oh, well, they didn't do this for me, they didn't do that for me. But I think with the generation that we have now, you're going to be looking at the socials and YouTube shorts and things like that, rather than the pamphlets or
Great.
that sort of thing. Does that make sense?
No, that's fantastic. Exactly what I wanted, and we can take that away. And I think what we should do, Caroline, through the chair, if that's okay, is make that an action for us to look at from a comms. How do we engage with the service? And maybe you can help support that. I know Rebecca's got a hand up. The different social platforms that we can use, because there is a growing generation gap between the use of technology and different platforms, and it's constantly changing as well. So anything that you can do to work with us on that, but we can take that away, and it's a really good point. So thank you for that. Very helpful.
Thank you, Michelle. Rebecca.
I suppose just thank you. Just thanks so much, Charlotte, for sharing the story, and really appreciate you sort of talking so positively about your experience. I suppose just to come in on a few of the questions that Charlotte's really answered really well for me, so I don't think I even need to be here. Just leave it to Charlotte. But in terms of taking it forward, there are some plans, because we're part of a provider collaborative. The lead provider is looking at doing some videos, and I think the aim would be for those to go out on social media and things. They've been postponed because they've been looking at the media bits, but that is in the pipeline, so hopefully they can link in with all the trusts, and they can be shared at a local level as well as across the north as well. So that would be one positive. As the other side of it is that NHS England are really pushing around the disadvantaged groups of veterans that we aren't seeing accessing services in the same way as the more mainstream groups. So that's Charlotte's very kindly volunteered to be part of a roundtable exercise looking at female veterans, but also LGBTQ veterans. And what we're seeing is that we're not seeing the right numbers coming through. So although we are seeing female veterans, we are seeing LGBTQ veterans coming through, it's not proportionate to the numbers that are actually serving. So what we should be expecting to see. So that would be something that we would like as a service to sort of get out there a little bit more, but also more positive stories like Charlotte's. As Charlotte said, we see a lot in the news and in the press about veterans that say, I've had PTSD for some time, I'm not going to get well. And we would really like to share stories like Charlotte more widely within the press, that, you know, as Charlotte said herself, it doesn't have to define you. You can move forward, we can support you to a positive outcome. And Charlotte's dreams for the future, she's bought her own house, she's resettled, she's supported her husband through his own transition from the military into a civilian job. So she's doing it, she's winning through. So she's very self-effacing, but she doesn't shout from the ceiling. She's just had a graduation, so she's there as a positive news story. And for us, we'd like that to be out there a little bit more, that the positive things that can happen and can be achieved.
Thanks so much, Rebecca. It's an interesting point you made about the LGBTQ, because recently I understand there was a decision that those members of the services who left because they could, at a time when they couldn't be gay in our services, they had their records expunged, and they were not able to sort of, refer to their status as a corporal, sergeant, or whatever. And I understand that has been changed very recently. And I think that just reminds us, there's a big campaign around that there's lots of those individual members of the armed forces who probably were never almost recognised when they were forced out, but also never probably came forward for support because of that happened as well. They probably weren't able to even access services, whatever they were, within the service itself. So it may be that there are people out there who went through that experience for whom, actually they do need to be able to feel that they can come forward as veterans in their own right. And maybe that has been something that has been denied them because of the circumstances of them being forced to leave the services. So I think that's another really interesting, I think, side to this in terms of those people as well. Okay, thank you so much, Rebecca. Thank you so much, Charlotte. Thank you so much. What's your name? The person next to Charlotte.
Hi, I'm Fernanda. I'm the patient care experience manager. So I've just been here.
All right. So
morning. Yeah.
Thank you so much for being. Yeah, thank you so much for being here and to support Charlotte today in person as well. We really appreciate it, and thank you for all your work. Thank you. Have a great rest of the week.
Thanks,
Make sure you get a nice cup of coffee.
But I'm not sure we got the best coffee at the old HQ, but you'll get a cup of coffee.
Bye, everybody.
Thank you.
Thank you.
Take care.
Well done.
All the best.
Thank you.
Brilliant. Okay, that's great. Thank you. That was really, obviously it's emotional, isn't it? But just such a demonstration of when services really can work together, it can make a difference, and it's good to know that so many things are working out well for Charlotte and her family. That's brilliant. Okay, let's move on then. Chair's report, I'll take it as a read. Any questions? No, let's go on to your report, Michelle.
Yeah, thank you. I'm just having a...
Sorry, Michelle, you've just gone on mute.
I'm on mute. Is everybody okay after that? Because it's quite emotional, so just have a bit of a breath, but do let us know. It was quite emotional for all of us. Anyway, good morning, everybody. Welcome. Thank you so much. Obviously, I will take it as read that you've actually read the paper. I'll pick out a couple of things as normal, but then I'm sure there'll be lots of other questions. There are a few policies to approve: the attendance management, the disciplinary, and the probationary period policy there. There's also the modern slavery statement contained contained in that. Now, it's not a separate report, it's contained in the report, it's at the beginning. And this is an annual statement that we have to acknowledge at the board, make sure that we're okay with the content of it and make a record of that. It's an annual thing. There's been no changes. I take it people have looked at it. So if you maybe have a think about that and then come back to me at the end if there's any issues, or pick anything up now. Couple of things, obviously the visibility, it's been a busy couple of months since we last met in this forum. Obviously we've had the strategic meeting in between, lots of visibility around Christmas. It was great to go around and meet the staff and the patients, but also the huge acuity that we see now on the wards is really more apparent than it's ever been, and I'm sure Lynn will touch on that when I hand over to Lynn for the update and the ops report. We obviously, I put in there about Jane Miller leaving. Jane Miller is the Chief Executive of Care Plus. She announced her retirement probably about 6 months ago now, actually. She's not retiring until May. So there's quite a lengthy handover, and Sean Stacey has been named as her replacement. I'm sure most of us actually won't, and a lot of us will know Sean. He used to work at NLAG, so he is aware of the area, and I'm sure some of us will know him. I've mentioned the research network. This is obviously the one I chair. Well, that will be changing because the arrangements are changing as it moves into the research delivery network. This is a national change from clinical research networks into regional delivery networks, which are making it more even more local and regional than it was previously. So there's quite a bit on there about it. So I took the opportunity to do that. And also in the report later on in the medical director section, the research conference is noted, and that's on the 19th of November. So if you haven't got your tickets for that, I would strongly suggest that you get your tickets, because they fly off the shelves for the ones in person, though obviously we do a hybrid approach to that. Lots of things happening around the winter that we're still in, and I'm sure Lynn and possibly Hilary will mention the reasons why we've gone back into universal mask wearing at the moment across our units, and that has proved to have a bit of an effect on our sickness levels. It has, I mean, there's lots of variables, but they have reduced a little bit. We are preparing ourselves for the CQC, so the board, thank you very much, have been involved in some of that, and we'll continue to do that alongside the rest of our staff. But Hull local authority have also having an inspection from the CQC, which we're involved with more as obviously as a partner, but more offline. Great work on the agency. So I thank my colleagues and the staff in relationship to reducing the agency, especially around healthcare support workers. As people know, that's one of the things I'm particularly taking a very keen interest in. Lots on statutory mandated training. We've signed the national guidance about which is at section 3.311, which sets out the national mandate for the memorandum of understanding, which starts to streamline training across the country, which is good. It's good to see our postgraduate work developing through PROUD. And we've had quite a detailed update from the medical education, which is extensive, and I thank Kwame and the team for that. A little bit about cyber updates, which I'll draw your attention to, and then as usual the communication, which has been quite a busy month as you would expect. We have got a board of trustees meeting later, but there is an update on Health Stars, which have also had a busy couple of months as well. So I'll leave it there, Chair. I'm going to hand over briefly to Lynn and any other colleagues that want to come in. Lynn, I just think it'd be useful just to go through a little bit about the pressures that we're facing, obviously because of winter. But please bear in mind at the end, I would like the ratification of the policies and the modern slavery agreement. Thanks, Chair. I'll pass over to Lynn. Lynn.
Thanks, Michelle.
Thanks, Michelle. So yes, I'm sure the board are aware, but just to recap, it has been an extremely challenging position in terms of wider system pressures, particularly immediately post-Christmas through to early January, where I think all of the acute hospitals in our ICB area were reaching that Opal 4 position in terms of those pressures. Underneath those, as the report describes, there was a rise, as you've already mentioned, Michelle, in the prevalence of winter viruses, particularly flu, leading to increased admissions, increased footfall through the emergency departments. Obviously, that had an impact on our staff as well. So there was a rise in staff absence. That did lead us, as you've already said, to consider the position for our services as well. So with Hilary and the IPC advice, we did make the decision to, certainly for our inpatient staff, to request them to wear universal masks, as you've said. They still are in that position right now because we are seeing some improvement in our sickness absence. We are reviewing it very frequently. Hilary will comment. We don't want to have our staff in masks longer than is necessary, but obviously we do need to protect our workforce and protect our patients as well. All of those acute hospitals were reporting a reduced number of discharges, so high demand but slow down in discharges from those hospitals. So there's been a system focus, as you would expect, on no criteria to reside service users and moving those through in order to improve that flow. That did lead to increased waiting times for ambulances as well. Offloading service users patients at those acute hospitals, and obviously then increasing delays in waits in the community. So a real focus on the patient safety quality agenda through that. Over the last week, those pressures have reduced somewhat. There still are some hotspots across our system as well. From our point of view, and we did maintain that Opal 2 overall position, but we did see some pressures in our community services in North Yorkshire. We've been really focused, obviously, in supporting the acute hospitals, supporting those discharges, supporting that flow, maximising our virtual ward, which I'm really pleased to say our occupancy has increased significantly. But from a mental health point of view, mental health services are and remain and had been at Opal 3 through that period. So we had seen increased demand. What we have seen through December and continuing into January is a rise in acuity of our service users in our learning disability service, as well as our mental health services, and indeed in our forensic services too. We have looked at that. We are addressing sort of what's underlying that increase in demand, but it does mean, along with those winter pressures, that rise in acuity has meant that it has been a very challenging period for our staff. So we're absolutely thinking about that staff health and wellbeing agenda as well, and doing our utmost, but better than it was for the first sort of couple of weeks after Christmas, but still quite challenging right now.
Okay, thanks very much, Lynn. Are there any other questions to Lynn before we go on to some of the other executive directors? Steph.
Thanks, Chair. Yeah, I just really want to compliment Lynn and the team on the work on delayed transfers of care and the MAID approach, and we see the graph there. It really does illustrate the focus that there's been over the last few months, and actually I don't know if it's a blip for November, December, but there's a real downward trend as well there. So that is superb work, and that's it. Thank you.
Thank you, Steph. Stuart?
Yeah, Lynn, thanks very much. In your report on page, it's page 10 of the report, and it's page 40 of the pack. Yeah, there's quite a long list, quite an impressive long list of initiatives underway to improve performance in a number of ways. Thinking about our performance report later on, are there any areas of our performance which is currently under par that are not covered by these many initiatives? That's quite a complicated question, but do you see what I'm saying?
It's a very good question. One I ask myself frequently, as you would expect, Stuart, to make sure that where we've got challenging areas of performance, that we have got an equivalent plan. The waiting times obviously are still our highest area of challenge, as this report describes as well. But in fact, the next quarterly waiting time report will be going to the next quality committee. I think that really does demonstrate, Stuart, that we have significant and robust recovery plans in place for all of those areas. Obviously, it is those neurodiversity waiting times for ASD and ADHD, where every which way we look at it, as we've discussed here many times, we simply do not have the commissioned capacity to meet the waiting times challenges. But that doesn't mean to say that we don't still have improvement work taking place. We're constantly looking at what we can put in place to support those children and their families that are waiting. So there are new initiatives sort of going forward all of the while. But I am confident, because I do check that for each of our area where we've got a performance challenge, that we do have a work stream under that transformation programme that is picking that up.
Yeah, and thank you. And is a risk of like initiative overload? Are there too many things going on to keep a real focus on the most important things?
That's a very good question as well, and again something we look at across the operational leadership team and indeed with EMT. Obviously these programmes have been happening certainly in 3 of our divisions with the rollout of the new EPR system. So we said right from the outset, before we even began the first phase of that we would review, and we did review this programme of work. So actually we have paused some and we are waiting to complete the rollout before we will bring some of those new initiatives on stream. So have done that, but also, you know, where we can maintain momentum around those transformation programmes. And obviously it is that time of year where we're looking at the operational plans for next year as well. So that's given us sort of opportunity to look at these programmes through the right lens again. Are these our priority? Are they covering the areas, as you say, that are, you know, priority from our point of view, but obviously in terms of the national and local system as well. So I'm confident we are doing that and checking and asking those questions, Stuart. But yes, as I say, I think, you know, and actually what we're seeing is this progress. The highlight report against all of these programmes goes to EMT once a quarter as well, and it's great to see we've closed a number of programmes in the last year too. So staff are really, obviously our staff do want to participate in improvement work, you know, but it is a balance, as you quite rightly said, particularly given the challenges that I've just described around the system currently.
Okay, thanks very much. Thanks, Caroline.
Thanks, Stuart. Kwame.
Yeah, thanks, Caroline. Just a couple of things in the section under medical director. There is a number of open lectures which is open to all staff, especially the one on sleep is really good. I've seen the speaker speak at a national conference, and it's about sleep and well-being for all of us. It's not patient focus, it's about. And then if people want to have a triangulation of some of the difficult conversation we do have about coroner's hearing, we have invited the Her Majesty's Coroner, Professor Max, who is coming to speak to us on the 28th. And if any board member wants to, it's going to be a question and answer session to get an insight into how we can work with him in a productive way. So if anybody or somebody who is listening on the call wants to be part of the conversation with Her Majesty's Coroner, is on the 28th of May, 2025.
Can we get an email round to everybody on that, just as a reminder? That'd be super helpful.
Yeah, I could do that.
Thanks very much. Thank you. Hilary.
Thanks, Caroline. Just a couple on mine. Just picking up the mask wearing in our inpatients. I think Lynn and I thought we might get a little bit of pushback, didn't we, from staff when we requested that. I was out on the units that week when we'd asked for that to be implemented, and the staff were really compliant and really got it. So we've kept them with us, and we've just kept regular comms with them to say that we are constantly reviewing it and the current position, and we comms will be going out again today saying we'll be reviewing it again next week, because we just do not want to keep them in mass any longer than we need to. So, but it was positive, the compliance from the staff. And just to pick up about the CQC preparedness, the inspection preparedness, we've got at the end of February, we've got Audit Yorkshire coming to talk to the board, go through the board at the strategic development about the well-led. We regularly meet with CQC. They've told us we will be inspected at some point this year. It is 6 years since we've been inspected, so we're well due. There's something coming to Quality Committee, Philip. We're going to be presenting all the work we're doing now, and we're always CQC ready, but when you sort of know it's coming over that horizon, we just sort of really up our game. So there's an awful lot of work, lots of handouts for staff, lots of mock inspections are starting. We do the peer review process anyway, but we just want to make sure that right across from ward to board, everybody's ready for the CQC and having those conversations with CQC inspectors when they appear.
Thanks very much, Hilary. Karen, sorry, Karen. Karen.
Thanks, Caroline. I just thought I would make a nod to section 3.310, so under my area of the report, so around the launch of the national consultation into manager regulation in the NHS. And I know obviously off the back of the CARC review and all of the work that was undertaken with regards to the fit and proper persons test and the leadership competency framework, this is currently in consultation, but it is and will be applied to all levels of leaders and managers within the NHS. As I say, it's going to be fully co-produced, it's in consultation, so I will certainly contribute to that where I can, but it was just to let you know that that is in the pipeline, and it will include a code of practice and a framework in terms of manager and leader competencies. I think having looked at the initial information that has come through sort of regional, national discussions about this, actually we're really confident that with our work with our own behavioural standards framework and being Humber, that actually we've got an awful lot that we can align into this. So it was just to keep you abreast of that work.
Karen, can I ask quickly, does that mean when you say it applies to all leaders, it applies to all non-executive directors and chairs as well?
I don't have that detail yet.
So I wasn't sure when I read it whether it was, you know, operational staff rather than, do you know what I mean?
It does say entry to exec as part of the framework.
That's what I
tell. But then aspiring manager to board level. So it's a bit ambiguous at the minute, Caroline, but I'll keep you up to date on that.
That would be really helpful to know, because when I read it through, it seemed great, and it seemed it was more appropriate for professional operational staff. Obviously, it's going to be extended further than that, I suppose, for, you know, part-time NEDs, not just ARTROS elsewhere. It's just hopefully if we are included, it's proportionate. In terms of, absolutely. You know, I mean, more important though it is, I think for staff, it's really key. Okay, I can't see anybody else's hands up. Can I just come back on one thing, because I think it's really important as a board that we sometimes on things, you know, express our support for something, and that's vaccination. Michelle and I, we've had a few chats recently, haven't we, Michelle, about take up of vaccination, and it's really great that on one level Humber is way above many other trusts across the system, whatever services they provide. But obviously hearing from Lynn, hearing from Hilary, and in the report itself about high levels of sickness absence, and we'll see some of that also in the performance report, but also needing to use masks again. We still could do more, and we would like our staff to do more to take up the opportunities to be vaccinated. And I just think that's a really important message we should send from the board. I will probably raise it in the board talk following this, because actually, you know, it is really seasonal flu vaccinations are an important, as it says actually in the report, public health intervention. And whilst we, you know, do have high rates compared to other trusts, we should always be ambitious for more, particularly where there's direct face-to-face contact with patients, particularly I think probably as well in inpatient units as well. And I know there's been discussions at EMT on this, but I just wanted to reinforce that at the board today. So I hope that's okay with colleagues on the board to do that. Okay, thanks very much. If not, I can't see anybody else's hands up, so we'll pass. Oh, sorry, let's ratify the policies. So we have attendance management. Is everybody happy to ratify that policy? Yes. Ratify that adjustment.
Just on that,
sorry.
I've sent just because I was involved in one of these. Okay. Just sent Karen some comments on tightening up some of the definitions. Subject to those, I'm happy.
Fine. Okay. Is that all right with you, Karen? Yeah.
Just definition tidyings up.
No, that's helpful. That's helpful. Probation policy. Any comments? Or brilliant. Thumbs up to that as well. That's 3. That's all of those. Thank you very much. We'll move on to publications highlights report. Michelle.
Sorry, Caroline. Can we just note and approve the slavery comment if people are happy with it?
Sorry. Apologies for that. Are we happy to approve the slavery, modern day slavery comment?
Thank you. Thank you.
Thank you. Thanks, Michelle.
Okay, thank you. Again, I want you've read the paper, the publication and policy highlights. These are all the main articles and publications that have come in during the month, with the relevant directors' comments on. The front sheet identifies them. It's just interested to know the Right Care Right person. We were an early adopter on that, so that's quite interesting. And obviously, we've done quite a lot of work on the Insightful board already. AI, I will mention that we are doing a lot of conversations and having a lot of work at the executive about AI, which will start to go into the subcommittee structure. But it's there, Caroline, just for noting, unless anybody's got any questions. Thank you.
Thank you. It's such a useful document. Hilary.
Not a question, just pointing out the assessing and managing risks across ICSs. If anybody's not read it yet, it's actually quite a good document, and I've discussed it with Oliver, and we're going to just revisit the way that we assess risks and bring some of that in. It really gives that breadth and depth to undertaking risk assessment, and I know it says for ICSs, but it's as relevant for providers, but it's very relevant, I think, as a lead provider as well, where you're holding the risk across a system. So just thinking about us with our lead provider role that we have as well. So Oliver's going to have a look at that, and obviously that will come back through the usual governance as that gets developed.
Yeah, thanks, Hilary. Well, we usually look at everything like that in relationship, whether it's a queue. Obviously, they did the work on the electoral reform, which is on the agenda, and I agree with Hilary. It is suitable for everybody, and we should look at making sure, just to reassure the board, that when we get things in, we do look and see how effective we are in relationship to that, even though they might not say mental health or community on them. So that's positive. Thank you,
Keith.
Just on a similar thing to number 8, your Insightful Provider Board report. I thought that was really useful. It's a really good read. And Michelle, I think it's it's useful to ask ourselves how well we measure ourselves against that in relation to assurance and stuff like that. It's quite a simple document, but simplicity is not bad in some respects. But it's actually a really useful read, I think, and it raises some interesting challenges.
Yeah, thanks. I'll pass over to Hilary because we are doing some work on that. Thank you. I was part of the author of that, so that's why it's probably simplistic because it's my train of thought. But thanks for that.
I didn't know that. Sorry.
No, it's all right. Well done.
Hilary.
Sorry, just to come back on that one again, that's on the strategic board development at the end of February, but we've had to condense it because we've got Audit Yorkshire coming and doing the CQC well led for everybody, and they needed a bit more time. But if the document will be coming out to everybody, and there's a bit in the document which are questions the board should ask themselves. So given we've only got a good half an hour, can I just ask the board members just to look at those, and perhaps those are what we will unpick in that session, if there's anything from any individuals that you just want to sort of have a discussion in that forum. And I mean, it'll be iterative, won't it, Caroline? I mean, the board will keep picking up as it goes along, but I think that'll probably be the best way of doing that session, if that's okay.
Yeah, I think that's great. And I think when we sort of met with Audit Yorkshire, didn't we, Hilary, they said they were going to pick up on some of the elements of Insightful board as well. And I think you were liaising with Mike, I think it was, just to see where, you can avoid duplication. So it's really 2.5 hours in a way, really, on both the CQC well-led review, and then obviously Insightful board is a part of that as well in some respects. But but we can always come back to it again if after we have that session in February as well. Thanks for that. Phil.
Yeah, not surprisingly, I had a good look at the future medical workforce paper, which was fascinating. I was a little blindsided. I didn't realise that the locally employed cohort of doctors had grown so much, and I think Kwame in the paper put some reassurance that these are not second-class citizens. But I just wondered if Kwame just like to just give us reassurance that any doctors that are not employed, that are not on a formal training scheme, are being well looked after and developed in the trust.
Yes, we have we call them specialty doctors and SAS doctors, and we have appointed a special SAS tutor. And we do have regular meetings with them. We have put all of them on what we call career portfolio platform to make sure that they get opportunity to grow to become consultant. And indeed, a few of them have been promoted recently in some of the reports I've made. We're working with the GMC to make sure that and the Royal College to make sure these doctors are treated equally, giving them career opportunities. And most of the opportunities that we offer, such as to be lead, we offer it to our SAS doctors as well. And indeed, I think one of the opportunities, when I get one of the opportunities, I'll bring one of the doctors in to talk to us in the staff experience to be able to share all the opportunities we're giving to them in Humber. So I'm really proud about the way we're treating our SAS doctors in this organization.
Thanks, Kwame.
Great. Okay. Any other questions? So if board members could have a look at that paper that's in the report on the Insightful Board, and particularly the questions, as Hilary has said, before we meet at the end of February to discuss it further, that would be fantastic. Thank you. Okay. Thanks very much, everybody. Let's move on then to Lynn, item number 9.
Thanks, Caroline. So I assume people have read the paper, but obviously this relates to the Reforming Elective Care National Plan that was published on the 6th of January. And whilst the plan is focused on elective and acute care pathways in terms of recovery of waiting times, it does have implications for us. And within the plan, there are expectations around primary care, particularly, and impact on our North Yorkshire community services, especially with the opening of the community diagnostic centres and services. So in terms of the impact of those on patient pathways. So the plan aims to achieve the NHS constitutional access standards for elective care. So that's the 18-week standard by March 2029. So organisations are required to have a directed lead. So I am the lead for the trust. And whilst it's not focused on mental health waiting times and recovery, I do think it does give us an opportunity to consider the methodology, the approaches that are contained within the plan and how they might be applied to some of our challenging pathways that we obviously spoke about earlier as well. So I hope that just gives a brief overview, but very happy to pick up any questions.
Thank you very much, Stuart.
Yeah, this might be a foolish question. What is the equivalent of elective care for our sector? Do we have such?
It's a good question. Not as such, Stuart, but in fact, Michelle's talked here before, as have I, that, you know, we do have some sort of standard pathways, access to our community mental health teams, for example, our newer developmental pathways that we've just talked about now. If they were considered in terms of a priority in a similar way that some of these elective pathways were, you know, would we see some sort of impact, you know, particularly children's waiting times, which we've spoken about many times, the impact of those, you know, and waiting times, that there is a finite opportunity to intervene with those children. And actually what we're storing up is issues for the future, isn't it? So, but no, elective pathways are pretty well defined. Sarah obviously is here today.
But we could identify sort of a category equivalent for our area. The other thing that struck me is that we report on the numbers of people in our queues. This policy talks about the percentage of a population waiting, so we might have to think about how we measure things.
Karen?
Thank you.
Yeah, just wanted to add in, obviously the report makes reference to customer care training as one of the expected steps within there, and it was just to update really. So we made quite some strides a couple of years ago now actually to implement customer care training to those in non-clinical patient-facing roles and in corporate functions as well. So what we're doing is making sure that on the back of this, that we've got a focus of this in our annual training plan, just again to complement this wider work and just make sure that we're as far-reaching as possible. Thank you.
Thanks very much. Just to share with colleagues, meeting of the Mental Health Chairs Network, I think it was the end of last week, we had a really interesting discussion and a presentation on waiting times and how they apply to mental health services, because so often in the public domain it's really about, isn't it, emergency departments, and I will share the slides when I see them with everybody. But it was quite an interesting discussion around you know, mental health being much more brought into this debate about waiting times, and we all know the complexity of that and challenges. We've talked about that many times, but also part of the presentation was about the sort of questions boards should be asking for. And to be honest, I was one of them. There were several others on the call, because I just happened to have my board paper here, where they started talking about the performance reports. And obviously there's quite a lot of variation, it sounds like, out there. I don't think we're behind the curve, certainly in terms of the information we have, but it was quite interesting because, you know, they raised a couple of things and I immediately went to the pack, Pete and Lynn, to just check what we were doing. And I'm glad to say there weren't any particular red flags for us, but it made me think about, oh, that's interesting, you know, that maybe there's a discussion at some point about just really looking, not changing anything, but what questions are we asking? So I will share those slides with everybody. And maybe that's something, you know, again, as part of this waiting time debate that's developing, and this is part of this elective care, isn't it, Lynn, as well? It's not the only thing, but it's part of it. We might want to sort of look at.
Definitely, Caroline. So I'm glad you didn't see any gaps. We do have the benefit of having colleagues in our trust now who do have that acute care background, who have worked and have, you know, extensive experience of elective recovery. So where there is a methodology that we think we should be applying through that experience that are relevant to our access and waiting times, I can absolutely assure you we are applying it, which is why you will see a lot of work and focus obviously around that capacity and demand analysis in the quarterly report that we produce. But we would want, I think we'd all agree, that you know, that sort of understanding and focus on mental health waiting times to increase nationally. That might put us under some pressure, but absolutely, particularly around children's, you know, for the reasons that we've discussed. But it'd be good to see that slide deck, Caroline. Thank you.
I'll share it. I'll find it this afternoon. Okay, thank you very much. Okay, let's move on then to the finance report. Pete.
Thanks, Caroline. Sorry, I couldn't get myself off mute. So this is the finance report at month 9. You'll see the system context within the report, and we've discussed this many times, but the most recent ICS finance information at month 8 is still indicating approximately 65 million of risk to deliver in the financial position this year. And we had a bit of a conversation on that at Finance Committee last week. You know, meetings are continuing to take place across the system with providers to look at what is the best possible outturn position we think we can achieve. And I think this will inform a discussion at month 10 with the system and NHSE about whether or not to invoke the forecast outturn protocol. And we had a good conversation about that at the strategic board in December. So I think it's fair to say the system is challenged at the moment financially. In terms of the trust, you'll see at month 9, we recorded a position where we were slightly away from plan, but that was due to the cost pressure for the pay award. And you'll see in the paper that the 2 risks we previously reported to the board have progressed since the last board meeting. So we've had verbal confirmation that the 933,000 we assumed in our plan is committed and will be transacted, but it hasn't been transacted as of yet. But we've no reason to believe it will not be transacted. And we have received some non-recurrent support from NHSE to support us in managing the pay award pressures, and that will be reflected in the month 10 position. So we're continuing to forecast to plan and have no reason to expect we won't achieve our plan this year. And you'll see our cash position remains stable, and you can see our better payment practice performance is in the report. I know we had a conversation at Council of Governors on that, and just to reiterate what I said there, the bulk of our non-NHS failures on BBPC relates to agency and pharmacy invoices where we do have queries, and we are encouraging people in the trust to put those invoices on hold, and we've got a targeted piece of work just to look at that to try and improve our BPPC. So I'll take the rest of the report as read if I may, and I'm happy to go to questions.
Are any questions from colleagues? No. Can I just ask one then? The attachment at the end of the actions checklist, it's got all the organisations who are responsible for doing different parts. Do we get to see when they start putting who the owner is on it and when it's expected? Is that being worked up?
It is being worked up through the ICS, and I'm happy to share that when I've got a completed version. That'd
be brilliant. Thank you very much. I think that'd be really helpful. Thank you, Pete. Okay, I can't see any other questions, so we let's move on to the next item, Pete, on the standing order scheme of delegation.
Thank you, Caroline. So our scheme of delegation is due for full review in May of this year, but there's just a couple of areas that we feel would be beneficial for amendment now if we may with board approval. So 2 parts to the paper. The first is procurement thresholds, and with the publication of the Procurement Act and the changes on thresholds, we had a conversation on our current thresholds at exec and agreed that probably it was timely to review them because they haven't been reviewed for a number of years. So we are proposing in the paper that we raise our procurement threshold to 75,000 for goods and services and 250,000 for estates related works. And just for context, both of those are below the Procurement Act threshold, which is 5 million. And then we have done a bit of tidying up on the paper for the SFIs to reflect. We disbanded the Charitable Funds Committee last year and we've got the revised governance in place. So hopefully that summarises what's in the paper. Happy for any questions.
Thanks, Pete. Stuart?
Pete, thanks a lot. This makes sense to me. Just one quick question on the so this is goods and services between 10 and 75 and works from between 10 and 250,000. So the proposal is to have to obtain 3 or more quotes.
Yeah.
It's important we're as open and transparent with our quote finding as well. What's the process for finding a quote? And can we do something that's a bit short of a local tendering process to make sure that we're not going back, or do we have sort of approved suppliers list or ways in which we can identify where to get quotes from in a transparent and competitive way?
We use a bit of software, Stuart, called Quick Quotes, which our supplier network are all familiar with and our procurement network will publish. So it is almost a mini tendering process. It's just not as formal as on competitive tender. So we go through the quick quote process.
So it's fairly open markets, and thinking about supporting the local economy, local suppliers, if they know that mechanism exists, can find a way of pitching into the quoting process. Yeah,
absolutely.
Thank you. That's good. Thank you.
Happy with that, Stuart?
Yeah.
Great. Okay. Seems common sense, the suggestions in this paper to me. Okay, I can't see anybody else's hands up. Is board happy to approve the suggestions made in this paper? Yeah, brilliant. Okay, look, I'm going to suggest we just take a 5-minute break before we get into the performance report. So it's 10:50, if we can come back at 10:55. Welcome back, everybody, to our board meeting. I've just discussed with Pete in that short break that we'll take item 13 and then follow that up with a performance report, because we have Sadie Milner here, who's presenting on the Safer Staffing 6 monthly report. So over to you, Sadie. Thanks for being with us today.
Thank you, Caroline. Thank you. And thank you, Hilary, again, for inviting me to come and present the latest 6-month Safer Staffing report. So this current report covers the period, 6-month period from April to September 2024. In line with the national reporting requirements, we conduct our Safer Staffing reviews twice a year. And this round of reviews took place throughout November and December, following a period of 3 to 4 weeks worth of dependency data collection, which was done in October. So the method for conducting the reviews remains the same. We use the triangulated approach, using the evidence-based acuity and dependency tools, such as MHOST. We look at the staffing, sensitive quality and patient safety metrics, and have the professional judgment discussions. So reviews take place with the ward managers, the matrons, service managers. They also include the finance team and our e-roster team, and the reviews are led by myself and the Assistant Director of Nursing and Quality, Tracy Flanagan. So all 19 inpatient areas are covered in the report, and the report is presented by division and by ward and compares data from the 3 previous reporting periods reported as 6-month averages. So in section 2 of the report, the benchmarking data from the model health system relating to care hours per patient day is presented, and you will note that we continue to benchmark higher than the national averages in relation to care hours per patient day. Section 4 of the report outlines some of the limitations, where we note that evidence-based tools are less reliable for wards where there are low patient numbers, and that we don't have evidence-based tools for all of our units. However, following consultation with NHS England, we've recently obtained the licence for the updated Safe Nursing Care tool. That was obtained in November. So following a period of training, we're looking to roll out and introduce this at Malton and Whitby. So following the reviews and in considering the quality indicators, all 19 wards have demonstrated good assurance. I just want to bring a few points, key points to note. So care hours per patient day remains strong across all units, with Newbridges and Malton being the only units that are not consistently missing their target. Newbridges is slightly under the current target for the 6-month average, but it does align with their current recommended care hour per patient day as per the MHOST tool. We've previously noted that the care hour per patient day target at Malton, which is currently set at 8, we don't have a validated tool currently on which to make a recommendation. However, they do benchmark positively against the peer median, but we do note that the data in relation to this is somewhat limited. So the introduction of the Safe Nursing Care tool will support us moving forward in setting an evidence-based target. So therefore, it is recommended that no changes are made to the target care hour per patient day until we've introduced the new tool. Care hours per patient day at Town and Court remain high, and whilst again there is no validated tool to make a recommendation, we do look towards the national data from the model health system, and Town and Court consistently exceed this over time, and that's in part due to their low bed occupancy. We did discuss this in quite some detail at EMT. I noted that you were speaking earlier about the sickness rates and noting the work that's been presented to EMT around sickness rates, and a focused piece of work has been commissioned around the enhanced support for teams with rising sickness rates, with a focus on health and wellbeing of our staff and those returning to work. The Humber Centre have also done a deep dive into their sickness and developed a sickness intervention plan following a rise in sickness over the Christmas period. Safe staffing incidents across wards were relatively low, with minimal impact on patient safety and care. However, additional information is included in section 6.4.1 of the report, where a number of staffing incidents were reported at the Humber Centre. The report notes some of the challenges around short notice sickness and reduced staffing numbers when patients are transferred for emergency care. In order to support short notice sickness, registered nurses on nights has been increased from 6 to 7, and the duty nurse responsibilities have been reviewed and strengthened. So in summary, following review of the key performance measures, all wards demonstrate good assurance, with no ward with more than 2 red flags over the 6-month average. We continue to benchmark positively against our peers when comparing data from the model health system. Incident reporting continues to demonstrate a positive reporting culture with a high proportion of no harm and low harm incidents reported. Appraisals, supervision and training compliance is high. Sickness does remain a challenge across the majority of our inpatient units. And moving forward, we'll be introducing the Safer Nursing Care tool in 2025 for Malton and Whitby. And we're also looking to reintroduce the Community Services Safer Staffing tool. This was stepped down by NHS England last year, but it's now been reviewed and revised. So we'll be looking to introduce that later this year as well. So I appreciate there's a lot of information in this report. So I'll pause for any questions. Thank you.
Sorry about that. I said, Hilary, is there anything you'd like to add before I bring in colleagues?
No, it's a few times now that you've had it in this new format, which is trying to triangulate everything. So I hope it's doing that for the board, bringing all those quality metrics in as well. Really good discussion when this went to EMT a couple of weeks ago, when we started to look at it through that productivity lens as well. So we're going to do some work with that. It's the richness of data that's in it that can make us have those sort of discussions around productivity. But just the work that Sadie and Tracy put into this is commendable, with the divisions as well. Everybody's behind it. So I'm quite assured that this is an accurate report. From my perspective, which is the important point, isn't it? Thank you.
Yeah, thanks, Hilary. Sorry about that mute. I think it's a really good format report, and it'll be really interesting to see how it will look like when the productivity sort of lens is in there as well. Phil.
Yeah, I've been preempted a little bit. My question was about how I feel very assured by this report from a safer staffing perspective, but it's how do you then sort of look for productivity, and does this help or does this hinder looking at areas where it'd be sensible to make productivity gains?
Yeah, Michelle would just like to pop in.
It is a really good point, and as Hilary said, we did have a long conversation about this at the exec management team when it was presented. And first of all, can I reiterate what others have said about Sadie and the team for this report, because it has developed over the past year or so, and it is a really good report, and that's hence why we could get into the conversations that we did in relationship to productivity. I don't like that word, but it was just a bit of how can we use this data in relationship to some of the work that we're doing around effective use of our staff, which is obviously the biggest interest to us, especially going into what's going to be a tough year, but also maintaining that patient centre, because it's really good that we've got really high patient per day. But one of the things that we did have a look at was obviously the occupancy levels and how are we equating that into out of area placements as well as utilisation of our beds and that acuity or whatever. So we did have a long conversation just to reassure the board on that. And what we've asked for it is for this report to go into our productivity group and then be fed into the quality committee. So and obviously back to the exec team, so that we can have a look at both of it through the quality lens, but also through that productivity lens as well. Because it does ask a few questions, I think, when you read it in the round. But it's a really good report, gives us good data, and I think because we've got it in such a good place, we can then drill down on it a bit more. So that's where we're up to with the productivity piece.
Yeah, I suppose when you've got certain staffing levels for a certain number of patients, but it's about if you haven't got the number of patients in the beds, how does where do the staffing levels fit with all that, and what's the flexibility, isn't it? We've had some chats about that, haven't we, Michelle?
Yeah.
Okay, are you happy with that, Phil? Brill. Okay, Stuart and then Steph.
Yeah, very good to hear about the. Well, I was thinking it's more than. I was going to say triangulation, but it sounds like there's more factors, and my octangulation or something going on, which is good in terms of methodology. Interesting variations in sickness levels, and I think I heard you say there's practices in play to support people in terms of return to work and so forth. Are there any kind of, without giving any details away, do there appear to be any sort of local leadership or management factors across units which correlate with propensity to attend as opposed to not attend work?
Karen, would you like to pick up on?
Yeah.
Sorry, Hilary. No, over to you, Hilary.
So I was going to respond, but I saw Karen put a hand up. So I didn't know.
We could team it, Hilary. So do you want me to go, and then you might want to add into that? So what I would say is absolutely what we do is because we're really targeting some of those areas with the highest propensity of sickness absence, what we are doing is almost that holistic view across all of their workforce metrics to see if there are any red flags. So have we got high turnover, dissatisfaction through surveys, etc. And that would then indicate to us that potentially is there more going on here rather than viruses, things like that. So it's that wholesale approach to not just tackling the sickness as it happens, but understanding the culture, the leadership in that area, so that actually what we can do is resolve the root cause rather than the subsequent sickness that comes off the back of it. So absolutely, it's obviously a work in progress, and we are going to see a report into EMT in February time around the early stage impact of that piece of work. But like I say, these things sometimes take a bit of time.
Yeah, I mean, and it'd be interesting to report back in due course whether it's just down to the kind of the happenstance of incidents of sicknesses, or are there other factors which can be actually managed, as opposed to simply treating people to be better to come back to work. Thank you for that. Thanks.
Thanks. Did you want to add anything to that, Hilary?
We were just going to say that there was a lot of work going on around the inpatient units and targeting those sickness, which Karen's just alluded to. I've also said about let's start now about the flu vaccination uptake and really getting that message across, particularly in our inpatients, which are quite startlingly, some of them are quite low in terms of the uptake. So that work's carried on as well. And just again to give some reassurance to the board that Lynn and I meet with the Band 7s, which are the charge nurses of these units, regularly, so they have that opportunity. It's not an agendaed meeting, it's an informal chat, anything that they want to raise, if we want to raise, etc. So we've got that mechanism as well, that communication mechanism that supports a lot of this work as well.
That's good to hear. It's good to hear. Steph.
Thanks, Chair. Yeah, this is the first time I've seen this report, obviously because I'm relatively new. Really good read and really thorough. In particular, it was really good to read about the impact of our staffing levels on patient safety and quality of service on those occasions where we're not meeting the staffing numbers that we would really like to have, which enables us to consider what the risk is around this really thoroughly, and that was really helpful to understand. I'm interested in the reaction of our staff on the ground to this approach. We've talked about the professional consultation we have with our line managers and our senior staff. But one of the key things around staff satisfaction is feeling that staffing levels sometimes are too low, and that causing stress for individuals and causing dissatisfaction with workload. Obviously, this is part of the communication to staff that we are taking this matter seriously, that we are considering it in the round. How have our staff on the ground responded to this approach? It's obviously a public document, so everybody can see what's being looked at. But what's the feeling around that, and what impact is it having on staff morale and staff responses?
Am I okay to come in on this?
Yeah, absolutely.
So when we do the reviews, we do speak to the ward managers and the Band 6s, and get a sense of, it's that temperature check, isn't it? Do the staff feel safe? Do you feel safe at work? Do the staffing levels feel safe? And on the whole, we get a positive response. But I do wonder whether there's maybe something about whether we include metrics from the staff survey in this report, just to give that more balanced response, really, because like I say, we're just relying on the feedback from the ward managers and the Band 6s. Maybe we need the voice of the staff on the shop floor in this report, potentially.
Yeah, I think that might be helpful, and at the risk of adding to the quadrangulation effect, it's so important, isn't it, that it might just be worth considering that as well.
I suppose as well, Sadie, in terms of sickness levels, obviously, you know, it's interesting hearing from colleagues around what work's going into that, and you know, people who are off sick coming back in, but it has an impact for those who are at work if those people aren't there as well, and pressures too, because obviously they're having to cover, they may be called in, and I know from visits to units how much, you know, it's a real sort of concern as a team to make sure there's cover, and often people are called in, aren't they, and are willing to sort of go that extra mile, to be honest, to make sure that, you know, patients are looked after. So it is about, yes, the people who are off sick, but it's also about the people who are not off sick and the impact on them too, and hearing from there. I think that's important not to be lost. Okay, Keith.
Yes, thank you. Really, again, like Steph, first time I've seen this report, but really, really insightful, really, really useful. I was just going to add into that end of that previous conversation about, I wonder whether additional triangulation with the staff survey questions and bringing some of those in around that, how the wider staff feel in that terms of safety, some of those questions would help. Not give you necessarily a different answer, but give you more depth to the answer maybe, and more triangulation around the answer, but really helpful report and really useful.
Thank you.
Thank you, Keith. Anybody, excuse me, anybody else? I can't see any other hands up. Thanks, Sadie, and thanks, Tracy, and everybody working on this. I mean, I think first of all, it's a really readable report, which is easy to understand. And there's obviously a lot of work going on. And also what's good to see is in some ways more work going on to fill in the gaps and do the work. Really great to see the work's being done with some of our services where there isn't a tool that fits exactly, but we're trying to make sure we can provide the rigour in those services as well. And good to hear about the community services too. So thanks, Sadie, and please say thanks to everyone in your team who works on this. Really helpful. Look forward to the next one.
Thanks ever so much. Thank you.
Okay, great. Thank you, everybody. So let's go back to the performance report. Pete and Lynn handle this. Thank you.
Lovely. Thanks, Caroline. So firstly, apologies for the title of the paper in the packet. Just say performance at the end of October. It should be December, and I guess that's what happens when you start your report from a previous month as a template. So apologies for that. I guess at the end of December, our performance is broadly consistent with what we reported to the board in previous months, but I'll just pull a few items out, if I may, and then perhaps we move to questions. So firstly, incidents per thousands has gone up, but that is affected more by the number of contacts we recorded in our clinical system rather than the number of incidents that we're actually recording. And we suspect that might be a consequence of the change in clinical system and the EPR migration. Similarly, the over 52-week position at the moment, that is impacted by the data migration and the switch to EPR, and we are working through the data quality issues. We've talked about the targeted intervention on sickness on the last paper, so I'm not going to repeat what's been said, but we look forward to seeing the outcome of that work at EMT and People and OD Committee. And finally, whilst it wasn't on the front sheet, but we did touch a bit on this earlier in the Chief Exec report, we have seen a reduction in our patients clinically ready for discharge, and some of that is supported by the work through the MAID events. So I will stop there, Caroline, and just open up for questions. I think you're on mute, Caroline.
Gosh. Questions from colleagues? Stuart.
Got lots of questions, but I'm conscious of time. Can I ask for so looking at the goal, sorry, let me be clear about this. Is page 21 of the report. It's PAC page 120. And it's the number of patients waiting 52 weeks for an assessment and diagnosis for adult ADHD. And what I can see there is a line going quite significantly down from, I think it's August 24 to now. How are we achieving that?
Thanks, Stuart. If I respond to that, Caroline. So I think I explained this last time we met, Stuart, because we've achieved that, unfortunately, through temporarily closing the access to new referrals. Meanwhile, we've also done some really detailed waiting list analysis as well. We've contacted every service user on the waiting list because of the length of time. Some have been waiting just to double check that they still require access to the service. There's been some response to that, and in agreement with our ICB colleagues as well, we've provided information to all of those on the waiting list that they can choose the right to choose route to access appointments as well. So all of that collectively, cumulatively, has resulted in the reduction that you see.
Yeah.
So obviously that means that we're now in dialogue with our commissioners around what we do as our next step, now that we've taken this one to temporarily close the waiting list.
Yeah, thanks for confirming that, Lynn. And then kind of turn to pages 122 of the pack, and it's the pediatric ASD data and pediatric ADHD data. So we know we've got this kind of persistent rising trend, which we talked about before, and you've referred several times to a continuing discussion with the commissioning function, essentially, about what can be done. Are we seeing any progress in those discussions in terms of a response or timescale for resolving, or are we just going to continue to see this rising demand? And the reason I ask that is, as a board, if we don't see other resources coming in to deal with this, as we approach our own planning round, which we'll come to later in the day, is there a chance to say, do we redirect resources from other sources of funding that where we've got some latitude into tackling what this looks like a kind of this feels like the burning platform, probably, given the scale of the population being affected here. That's a strategy question, actually. It's not a performance, it's a strategy question.
Fair question, Michelle.
No, it's a really good question, Stuart, and it is one, I think, once we've got the planning guides, obviously we'll have a bit of an update later, but which is due tomorrow. Then we will probably need to make some decisions about if we move resources, because I think we will be looking at not a lot of uplift from a mental health perspective, if I'm being on the positive side, to be honest. SDF may go into baseline, so if that happens, then obviously we've got the issue around if that then gets decanted out to the areas that it needs to, and obviously the mental health investment standard, we don't know what will happen with that. So I think these are exactly the conversations that we will need to be having around where are our pressure areas, where are our platforms that we really do need to move resources to, based on our health inequalities work as well. And that's the conversations that we will need to get into over the next couple of months. So the exec team will obviously do that to help support that process and bring that back to the board for some final conversations. But it will be difficult, and we will have to make some tough decisions, I'm sure.
Yeah, I think it'll be a choice for us as a board in setting our plan, where we're going to tolerate what we feel is not acceptable performance levels in an ideal world versus what we're continuing to continue, where we're continuing to maintain current service levels. And that's a really big, it's a big choice. It's an important choice that we should explicitly make, as opposed to just simply roll on without asking that question, in my view.
Thank you, Stuart. Any other questions from colleagues? Oh, Phil, sorry, Phil.
Yeah, he's just following on the back of that again, and it's I think when we start making our choices, if we can't solve the waiting times, then we may have to think about what investment we put in supporting people on the waiting list. And we've talked a little bit about that, but I just want to reiterate it, that we need to make sure that we maybe partner with maybe some voluntary agencies and give people a list of places that they can get support from, and that we do some level of risk assessment, which I think we already do. But I'm thinking particularly with the children with neurodiversity, I just really want to just keep it in the forefront of our minds, because I'm quite anxious about this. And the solution feels multifactorial. There's a societal decision to be made, as well as a trust and NHS decisions to be made about how this is dealt with. But I just don't think the system's supporting us well enough at the moment with this.
Thank you, Phil. Lynn?
Yeah, I just want to come back in on the point about what we do to support those waiting. So, Bill, I think we do an awful lot. We already contract with the voluntary sector to help us support those children and families waiting. Some of you were at the launch of the Children and Learning Disabilities website, and the whole purpose of that, obviously, that's an outward-facing website to signpost children and families to really useful resources in terms of support and contact. You know, there is only so much within our resources, and I think that decision around choice going forward for us as a board and for the system as well, because obviously as we keep discussing, neurodiversity waiting times are a challenging area for the whole of our ICB, and there is work that's taking place around that as well. I don't disagree with anything that's been said, because I think Michelle's indicated that unfortunately we're not likely to be in a position with that's going to be sort of recognised as an area for further investment right now. So it's going to be very difficult sort of making decisions around that, but we're going to have to grapple with it. But we are doing a lot, Phil, to support children and young people waiting. Our waiting time standard operating policy requires us to be in contact with those families on a very regular basis. Those families do have our contact details, access to our duty systems for access if their needs obviously become more urgent during this period of time as well. And we do obviously look at those on a very regular basis.
Michelle?
Yes, we've got the strategic element really. I think Lynn's outlined the operational things, and we do do a lot of contracting with other agencies, as Lynn said, in relationship to Phil's question and others. But I think the really important bit, not just from our point of view about how we start to look at the choices that we need to make and how we need to utilise the resources that we have internally, we also need to feed that into the system, because that's part of the reason for doing the collaborative work. How can we maximise the resources that we've got as a system to the best ability? And that's with all the providers. So it becomes the sum of its parts, really. And I think we really need to, and that's the conversation that we're getting into with the collaborative. So it's not just about the structure and who does the commissioning and who holds that particular accountability. More importantly is how do we use that to the benefit of the communities and the patients by maximising the resource that we've got available across Humber and North Yorkshire, and how do we then start to prioritise the areas? And I'm sure the children and young people's neurodiversity will be one of those areas. So that will not just be a conversation for us internally to move those resources, it will be an external conversation as well about how we start to move some of those external resources to meet the growing needs of the pressures that we've got. So I think that's a really challenging time, but I also think it's a really good opportunity as well to really start to address some of these issues that we've been grappling with.
Thank you, Michelle. Can I ask, because I think when I first started at the Trust, and I remember, Lynn, you reporting about when we were looking at the open door, working with partners, and part of the, I suppose, strategy was actually to address that, and again, this is about people waiting often for an assessment, whether they are adult or children and young people, that there is something going on, but it may not be that the neurodiversity is the actual issue there. And then, of course, within that, there's a whole range, isn't there, of different things. And one of the things was about how do you make sure you can deal, and that's part of the waiting list. The problem is whilst people are on a waiting list, there's still a sort of possibly an expectation that they want to stay on that, regardless of any other intervention we might be doing. And I don't think there's been quite a lot of discussion in the public domain, I think, from health professionals. So this is from a layperson, obviously, point of view, but it's interesting sort of reading articles by psychiatrists and others, those working in this field, and there probably are very many different views on this. But about, we're creating a journey that really is just ending up with a huge amount of people. Partly social media is contributing to this, partly obviously in a positive way, getting people to come forward, reducing stigma and everything else. But also it's an issue around, and a debate, isn't it, about medicalising so much some of these issues around neurodiversity and tackling that. And I just wondered, whether as, obviously professional operational staff, when you're engaging with the ICB and others and other partners, how much you're discussing this, because I think there's something at the, NHS England level and at government level to support this, because we're dealing with a system that really isn't, it's broken in a way. I think we've said that before. It's not really working for anybody, whether they've got a neurodiverse condition or whether actually it's something else that's going on.
I absolutely agree, Caroline, that is the focus. I mean, particularly for both ADHD and ASD, what matters is the early support. So, and, you know, those are the conversations that we have frequently, repeatedly with our colleagues, particularly in our local authorities and with our commissioning colleagues, that actually where we need to focus, where our resources are best placed, are in that early support. Absolutely, and we should translate our resource primarily. But as you say, Caroline, there is an expectation around families, around diagnosis and the part that plays in that. But in terms of, you know, what's going to support the child and the family, it is that access to support. So education, schools are where, and obviously we have increased that over the last few years as well, that focus. It'll be interesting to see what the planning guidance says around that children and young people support, particularly in education. But those are absolutely the conversations that we have repeatedly and regularly. I think slowly but surely we're moving in that direction, but it's a slow pace of work because you know, funding unfortunately does inhibit that. But certainly we had conversations, and some of us participated in the engagement work around the NHS 10-year plan. We've certainly fed it into there very strongly as well. So it'd be interesting to see what happens with that going forward as well. But absolutely, I couldn't agree more around, you know, we need to sort of change the narrative around this, but it's early support in education, I think particularly, that is going to make the step change and difference for these children and families.
Thank you. Kwame.
Yeah, no, I agree with what Lynn has just said. I think that nationally everybody sees the neurodiversity as a system which is not, is almost, the word you use is right, broken. And I think the conversation is beginning to move from having a diagnosis and medicalizing these conditions to, in many ways, we are all, everybody has some kind of neurodiversity in the spectrum, and the conversation is going on to say, how can we make our workplace, our school places, what support can we put in place to support anybody who is on the spectrum, rather than put a set group of people to come for diagnosis, and then what else? So that's the conversation that is having now. Obviously, funding and also ability to support the most extreme end who have comorbidity is something that is being talked about as well.
Thanks, Kwame. Thanks, Lynn. I think it's really hearing from you as professionals, just sort of, you know, hearing what your conversations that you're having about this as well. Thank you. Okay, I can't see anybody else's hands up. So thank you. That's the performance report. It's got approved here, actually. Do we normally approve the performance report on the agenda? No, we don't, do we? We just have it for discussion.
Yeah, it's just to note, Caroline.
Yeah, great. Okay, fine. So strategic development meeting in February. You've got the agenda in front of you. Obviously, we've reflected earlier on in the discussion that actually we are going to have that conversation strategically about the Insightful Board and linking it to that discussion on CQC well-led and what that looks like, facilitated by Audit Yorkshire. And so I hope that agendas, we actually did, between us, Michelle, Stella and myself, actually pare it down somewhat to make sure we had some real time and quality discussion on those issues. So I hope that's okay with everybody. Is that, and we're starting a bit earlier as well. We're starting at 9:30. So if you want to get a coffee beforehand, turn up before 9:30 to have, if you want a chinwag, to meet people before we start formally. Okay, everybody happy with that? Brilliant, great. Assurance reports, Keith.
Thanks very much, Caroline. Slightly snappy one on my part because I had to turn it round the evening of the committee for the board papers, so apologies.
Thank you for doing that. Thank you.
That's all right, it's not a problem, but probably snappier than it might somewhat otherwise be. Pete's referred to some of the conversations in his report, so I won't duplicate that. I think some real positives around good, strong balance sheet remaining unchanged in the current strain. Really positive presentation of the Green Plan. It's in its final year, or just going into its final year, but we're ahead of that plan in terms of decarbonisation, and a really positive report, which was really good to see. Recommendation around so the EMT, after the last Finance Committee reviewed the BAF and some of the risk scores around the financial elements, and added quite a lot of commentary into the BAF, but didn't change any of the risk scores. And I think the challenge from Finance Committee back to the EMT is, given the financial strain, particularly in the system, and the risk that presents to us as a trust, do we need to review those scores, and are they as where we need them to be, or do we need to reflect that we may be in a higher risk score position than we would ideally be? And then the other addition, probably before I stop for questions, is looking to put a specific out of order Finance Committee meeting in for the towards the end of February to review the finance plans for 25-26 to fit with the, hopefully, as Michelle alluded to earlier, magical delivery of the planning guidance for next year. But we're doing it at the moment without that planning guidance. But that needs to also consider some of what might be a list of kind of unpalatable things that we might have to think about doing dependent on that planning guidance, so that Finance Committee can review that prior to it coming to the March board, Caroline, for the board review, with the likely completion then needed to be the final position at the end of March. Other than that, I'll pause unless there's any questions.
No, thanks, Keith, and thanks for turning it around. It's very clear, and that sounds a completely sensible way forward in terms of having that meeting in February as well. So that makes complete sense. Any other questions or comments from colleagues? No, thank you very much, Keith. That's great. Stuart, over to you, Collaborative Committee.
Thanks for this. It's my report from the meeting we had on the 5th of December. On the positive assurance side, a lot to be confident about. So all the providers have got routine monitoring status, and we always take time to understand the sort of the detailed quality and oversight arrangements there, which are strong. We had an interesting discussion about risks. All the 3 work streams did the risk assessment, and they were all currently reporting at 9, and we challenged whether that was maybe a little bit complacent, but they still are at 9 at the moment. We'll keep our eye on that analysis. But particularly the financial risk that we initially saw in the early part of the year about risk of overspend is now abated due to good work. Also pleasing to see was that each work stream has a series of development goals it puts in place for the year, and they're all on track as we kind of quizzed the stream leaders in each of the services there. And we had a really interesting discussion about the business case to continue to support the community eating disorder team, whose job it is to prevent higher cost admission. So just exactly the conversation we've just had, there's some really good evidence that early intervention in community prevents higher cost incidents in the non-community setting. So another great piece of learning, I think, on where to invest our money to good effect. And not in this report, but just so you know, I've just had the first blush of some unit cost analysis on this collaborative ride. It's really fascinating. So watch this space.
Thanks, Stuart. I some of the calls I'm on with other chairs, I've actually sort of shared some of the information around both our work in ED streaming and that's going on, but also this community working around eating disorders as well. I wonder if there's when we might get to the position on that to maybe, you know, write something up and put it in, I don't know, the Health Service Journal or something like that about, you know, some good news about things we're doing. Maybe that's underway. Michelle's put her hand up. I really think we're doing some stuff that's great. I mean, there was one chair on one call I was on who they've just started down, you know, this sort of the sort of ED streaming path. And we've been doing it for well over a year. So I really, Not that I was in competition, obviously, but I did sort of, just flag that we've been doing it as well. But we've got some great work that I think, we regional and nationalise, and just in publicising it is really worth it. Michelle.
We do a lot of the publicity already, and there's a lot more we can do. I mean, obviously we've done a lot of work with the awards and going into Health Service Journal, but just about the ED stream in particular, because it is a bit of a unique piece of work that we're doing. I think we're all quite shocked that it is so unique. So we're presenting it as a national, just an internal NHS England working group that Sarah Jane Marsh and others are at, and obviously Sarah Jane Marsh is the National Director for urgent care that we're presenting at now on our ED work. So I think it's helpful now, particularly because we've got more metrics, so we've actually got more data to share with people, and obviously the data is the important bit, and we can demonstrate the benefit that that's having on patients, but also on the ED units themselves. So I'm happy to share that with others, and maybe we could do that. But we will continue to do that. But great that you're doing that as well, Chair, and if anybody else can publicise it as well. Less so on the eating disorders, I must admit. We probably do need to do a bit more on the eating disorders when we get the costs and the metrics, which we've got now. But I think we could do a bit more on that.
I think we've got, obviously you have the data, and something to back it up. But I think that, the national, like the Times or the Guardian or things like this would be, they're interested, they're health people in stories of transformation and doing things differently. But we've got to have obviously the evidence and data to back it up as well. But yeah. Any questions to Stuart? Any more questions to Stuart? No? Great. And we'll obviously be discussing more, won't we, Stuart, in terms of the mental health provider, how it's going to work, and the learning from the collaborative work we've already been doing. So great. All right then. Thanks very much. I haven't got any items to escalate, and I haven't received notice of any other urgent business. No, nobody. So reviewing the meeting, have we focused on the right areas? Were the papers doing the job they needed to do to support you to do your role? Has everyone felt they've been able to say what they wanted to say and ask questions? And does everyone feel we've done it in a positive and respectful way? Any other comments on that? People happy?
I'm interested in Sarah's reflection. So Steph, apologies for nicking your questions earlier, but Sarah's what's your initial impression? I'm always interested in first glances.
Thank you for inviting me in to comment. I think my reflection was that the time that was taken on the patient story, the service user story, I found that it really mattered, and it wasn't tokenistic, and it was so powerful, and everybody really embraced that and that. So I really felt it kind of set out the tone of the meeting, sort of moving forward, the importance of that. So that really sort of hit quite strong for me personally. I think one of the things I've picked up prior to board, but also really emphasised during board, is how there's that ambition and strive to improve. So when it comes to national guidance, national documents that may have nothing to do with mental health or community providers, is that constant translation of where can we learn, what does that mean for us, how could we do sort of things better. And I think for me there was that ethos of what does that mean for us, can we do more, can we do better, can we improve, and ultimately sort of service users and staff being at the heart of everything you did. So kind of really positive for me to observe my first board. So thank you.
Thank you, Sarah. Thanks very much for those comments. And obviously we're looking forward to you starting and seeing as a regular face at these events. So, okay, fine, brilliant. So that's the end of this meeting. So it's just before 11:40. I'm going to suggest that we have half an hour break, but we come back at 12:10, so we can actually start a bit earlier than we would have done, which is great. And the subsequent meetings, we'll pull them forward as we need to as well. So I'll see everybody back at 12:10. For anybody watching our board today, I hope we've managed to provide you with some real insights of how we seek assurance for what we're doing at the Trust, and you found it relatively easy to understand some of the issues we've been talking about. And for you, those of you joining us at a later date, again, the same applies to all of you. Thank you. Thanks, everybody.